Hey guys, good evening. Who do we have with us here this evening? Looks like we have Ben Larson is logged in. Ben, would you go ahead and
Okay,
unmute yourself?
can you hear me?
I can hear you now. Yes, I can.
Okay, I'm here.
And we have Laura Quirk. And Laura, if you can hear me, I'm trying to unmute you. There we go. I've got Laura unmuted. Laura, are you with us?
Yeah, can you hear me?
Yes, I can. Yes, I can. So let's give it about another minute or two and see if anybody else joins us. And
Yeah,
if
okay.
not, we'll go ahead and start there. While we're waiting, guys, any questions about anything that I can answer for you?
Just want to know if you got my emails. That's all.
I got the email today. I got an email
Okay.
from you today, and I just got home about 15 minutes ago. So I have
Okay.
not. Yeah, I've not. I've been up to my ears and feet
I
today.
can imagine.
Yeah. Yeah.
So
So
so just check because I sent one earlier. So
okay.
you know,
Yeah.
when you
I
have
will
a
check
minute,
it.
that's all. Just
I will
wanted to make
check
sure
it.
they went through because I got nervous. I didn't have your right email or something. I was like, maybe something happened and it didn't work,
Well,
or I had it
there's
in wrong,
this.
or
We've got this new HODS email.
yeah, that's what I sent it to. Yeah.
And it will not work in my Google, in my Gmail very well. So I have to use Outlook, and so I'm having to use two separate email services. So it's a bit of a pain in the butt.
Yeah, no
Very
problem. I just wanted to make
cool.
sure that they went through.
Cool.
I thought maybe I
So,
copied it
so
down.
Laura, you're with us, so I can quiz you heavily this evening.
Yeah, I may have to. I just have to get myself in a quiet area. I have you unmuted, but I have a lot of background noise going on in my house right now. So if I can get myself quiet in a quiet area, I have no problem. I just got to get.
And tonight's webinar is nothing particularly difficult. It's just sort of an unusual thing that happened to me here about a week or so ago, where I had these almost back-to-back cases of just weird carpal tunnel stuff.
Okay.
Yeah. Ben, are you doing okay?
Yeah, I sent you a bunch of emails too, but I've got 5 tests all lower extremities, all difficult this week.
Oh,
So
geez.
we're probably going to do some.
I did see that, and I did see where you posted one for me to take a look at here. So, so was that a difficult one, also, or?
Yeah, I had 2 of them where it was bilateral lower extremities and shooting off all sorts of weird stuff with the EMG, and then one was like no response with the tibial nerve, and so
Nice.
yeah. It's
Nice.
been fun. I got 2 more tomorrow, so we'll see how those ones go.
Nice.
Both lower extremities. So
Cool.
Maybe it's a full moon because I've had bizarro world myself too. So
Yeah. Well, it looks like the broadcast is recording here, so that's good. So I'm gonna go ahead and start here. And again, guys, nothing hugely earth-shattering. It looks like Roy Adams has joined us also. Roy, if you can hear me, when you get situated, go ahead and unmute yourself. There we go. Cool. Okay. So anyway, again, nothing earth-shattering. There's a certain way, that we expect carpal tunnel syndrome to present electrodiagnostically, and I figured this would be a good time to sort of show you and share with you that that doesn't happen. Okay, no matter what we think, no matter what we want, sometimes these patients just don't fit in a box here. So I've got 3 cases. Want to go with them, go through them with you real quick, and then we can have some time for discussing the findings. And again, as always, please don't hesitate to interrupt me if you have questions here. So our first case, again, these were all seen the same morning here about a week or so ago. So this first case, a 75-year-old lady, comes in with the typical complaints of hand pain, weakness, paresthesias, says her symptom duration has been several years, but for whatever reason, it's gotten particularly worse over the past few months. Her past medical history was essentially unremarkable, and she was referred to me in hand clinic, by one of the orthopedic surgeons here. With this lady here, again, small lady, 5 foot, 120 pounds, but was, what was interesting and readily apparent is she had atrophy of her right thenar region. And if you guys have ever seen that in a severe case of carpal tunnel, it's quite profound. Range of motion was normal, except she had no active thumb abduction. She could sort of substitute a little bit of extension and flexion to get some function. But again, this is where you watch, when you ask them to do something, watch to see if they can actually do the movement or if they're doing something else. Strength, being 74 years old, her strength was normal, with the exception, and I was generous when I gave her 1 out of 5, for thumb abduction there. Reflexes, were good. She had diminished, sensation in digits 1 through 4, worse in digit 2. No upper motor neuron signs, negative Tennell's at her wrists and elbows, negative Phelan's test, for the median nerve, negative Sperling's test. So let me throw out the first question to you guys. Why would she have, this looks like it's carpal tunnel syndrome, but why would she have a negative Tennell's and a negative Sperling's test? Give me a reason why, these tests may be negative in a fairly profound looking case of carpal tunnel syndrome here.
Well, your still accuracy is only about 30%. So.
Yeah. Sensitivity and specificity really sucks, with these tests. Phelan's is actually pretty good comparatively, but, if she's got a bunch of atrophy and if she's killed off a lot of axons already, there may be nothing to, provoke.
Yeah.
So again, some of these, some of our, provocative tests are, can, really be, red herrings there. So did some nerve conduction tests. What was striking here, other than the fact that she had no, median sensory responses, is that her ulnar and radials were beautiful. For a 74-year-old lady, she had nice amplitudes. And again, guys, I use an orthodromic testing technique, so my norm for amplitude is 5 instead of 10. But again, this is pretty, pretty good looking stuff, for her, uninvolved nerves. But again, she had no response, as you might expect with somebody that has thenar atrophy. She had no, median responses.
Okay. So Mark, why do you choose orthodromic?
It's just a technique for me. One, it's easier and it's cleaner. Those of you that were at the symposium, you saw me and Dr. McKibben going back and forth about motor artifact. I totally feel that motor artifact will compromise your data. He would argue that, well, you're not fully depolarizing the nerve unless you get, motor artifact. I would disagree. with that, because I think I can fully depolarize the nerve and not get motor artifact. Okay, so again, it's just a technique thing, but the norms for amplitude are just a little bit different. Gives us a little cleaner baseline also. Okay, and honestly, the patient tends to tolerate it a bit better also, because instead of poking your stimulator right into the median nerve at the wrist, you're actually stimulating out in the digits there. So patients sometimes will be tolerate it, but either technique is good. Okay, it's going to be what you're comfortable doing. So just be sure that when you do whatever technique you eventually decide to use, just be sure that's your normative data is good there. So again, to review, sensories were all normal with the exception she had no median sensory responses here. Then we go to the motor. And so let's talk about the ulnar first. Her ulnar was normal. Looking here, she had normal latency. She had a normal distal motor CMAP amplitude. 47 meters per second across the elbow is normal there. So ulnar looked good. Now when we get to the median, this is where this is how I started my morning here. Okay, so I shocked her at the wrist, and I got no response. Okay, and there we go. And this is a screen grab from my system here. So I shocked at the wrist right here and got nothing. Okay. Then went up to the elbow, shocked the median nerve at the elbow, got this little itty bitty, response here, with an amplitude of 0.4. And, I'm really not confident that that's a median response because it is so small. Okay. So at this point, I'm going, oh, okay, this is sort of nasty here. Mm-hmm. So then when you don't get a response at the wrist, you got to go into the palm. And on this third response, I shocked her median nerve in the palm and got a nice looking unresponse. But the amplitude was only 3.4 millivolts, so it's still a low amplitude response, okay, because the norm is 4. So a low amplitude response. And then I figured, you know what, since I got this little stuff at the elbow, let me shock her ulnar nerve at the wrist. And so this fourth waveform is I shocked her ulnar nerve at the wrist, and lo and behold, I got a response here. Okay, so guys, we got a lot of moving parts here.
Yeah.
Okay, one nerve, one hand, we got a lot of crap going on here. Mm-hmm. Okay, so let's break this down. Anybody out there, can you summarize this for me in 1 or 2 sentences? Summarize for me what's going on here. And if you can't, we'll go through it piecemeal here.
Let's see.
Laura, are you with us?
Nope.
Laura Quirk calling. There she is.
I was muted. I couldn't get myself off of it.
Okay. So you've been paying attention. Help us out here. What the heck is going on? I mean, this is my first patient in the morning here. So what is going on here? Okay.
So you got no response at the wrist. You got a very, very low response at the elbow. And then when you stimulated the palm,
we went distal to the site of the compression, and we got a response.
Right.
So guys, what is that called?
So you got a conduction block.
Okay, and tell us how much of a conduction block, Laura.
Complete.
Oh, yes, complete.
Complete.
Yeah.
100% conduction block.
Right.
So
yeah, definitely at the wrist.
So why would we get something at the elbow here?
Is that more of an ulnar nerve response?
Yeah, I mean,
Yeah,
because look,
yeah.
we
Yeah.
got a little Martin Gruber going
I
on
was
here
just gonna
too.
say that of Martin Gruber because now you're getting
Yeah,
the ulnar. So if you add the amplitudes together between the elbow and the
it'll be
ulnar,
close.
it'll be
It'll be
close.
close. Yeah, yeah. When your amplitudes are this small, sometimes they don't add up. But if you add 3 or 2.3 and 0.4, it's 2.7. It's relatively close
That's
to
what's
3.
kind of close. Yeah.
Yeah. So we have a complete conduction block. Okay. Uh, we have a low amplitude CMAP in the palm, okay, and then we have Martin Gruber
Mm.
here also. So first patient out of the block, and I usually start my testing on the right side. So this is the first limb that I checked of the day, and I'm dealing with this, right off the bat here. Okay, so again, very atypical. How often in carpal tunnel do we see 100% conduction blocks?
Not very often.
Not very often. Yeah, that is a rare one. Okay, so what would you expect to see? And I've done giving it away a little bit, but when you go to needle that APB, what are you going to see? What potentially could you see
With the needle EMG, did you say?
of that APB? Mm-hmm.
Oh, APB. Well, you probably, if it's conduction block, you're not going to see any potentials because it's a
Well, you could see little or no, potential. Okay.
Because it's not technically an axonal lesion. It's a
well, it is an axonal lesion too. And how do we know that it's an axonal lesion? Look at our amplitude in the palm. Amplitude only 3.4, so that's a low amplitude response. So there's an axonal component in here also. Okay, so we have a demyelinating component, the conduction block. We have an axonal component. Then we have a Martin Gruber here.
Right.
Okay, so when I needled her, I did see some fibs and positive waves, and I saw this is her pushing as hard as she can right here. I think I gave her the benefit of the doubt and said she had 2 motor units that were firing.
So she had reduced recruitment.
She had significantly reduced recruitment, and they were fast firing. They were firing 25 to 30 hertz. Okay, so those 2 single motor units that were functioning were having to fire very fast to try to generate, whatever strength, would be possible here. Okay, so again, this is very, very unusual presentation here, and the mere fact that we did see a few functioning motor units tells us that this isn't a complete conduction block. It's probably a 99.9% conduction block, which might as well be, a complete on a conduction block. Okay, so to summarize here, we had no sensory response. Okay, so that's a sensory axon lesion. Okay, then we had all of this. We had near complete conduction block. We had a low amplitude CMAP, and we had Martin Gruber. Martin Gruber's a normal finding in, some people will say, up to 40% of patients. Okay, but we had a demyelinating component, i.e. the conduction block, and we also had the motor axon loss component, i.e. the low amplitude CMAP, and that was proven by the fact that we had an abnormal, needle EMG. We had fibs and positive waves. Now, let me throw out a board question, and Laura, you don't answer this one yet, okay? So, in a demyelinating lesion, typically we will not see any needle EMG abnormalities. Okay, what demyelinating lesion can we possibly see abnormal needle EMG, and what would that abnormality be on EMG? So I'm going to throw this out to Ben and Roy first, and see if you can answer this.
Oh man.
Oh, let's see. What would you see?
And I'll give you a hint. We're seeing it here in this case.
Okay, so you're saying what would we see? So it would be the fibs and the positive.
Fibs and positives are indicative of an unstable muscle membrane. So that is an axon loss, component there. Okay. So in a demyelinating lesion, either slowing or maybe conduction block, what is the only potential EMG abnormality that you could see?
Increased recruitment.
Not increased recruitment,
Decreased.
decreased recruitment.
Decreased.
Okay. So when you use the term decreased recruitment, I want you to be specific what that means. And in this case, what it means is there's a significant reduction in the number of volitional motor units. Okay. There's not enough motor units firing. Okay. So in a conduction block, if you had, for example, say a 75% conduction block, would you expect to see full normal recruitment? No, because if 75% of that signal is being blocked, then you're not going to generate the number of motor units that you would expect to see. So that screen is not going to fill up, like it should. Okay. And in this case, where it was probably 99.9% conduction block, this lady was firing 2 motor units. Okay. And they were fast firing. They were firing 25 to 30 hertz times per second to try to generate strength. Okay. So in this case here, how would we grade the severity of her carpal tunnel syndrome? Would this be borderline mild, moderate, severe, or very severe?
Very severe.
Roy, what do you say?
Oh, geez. I was going to say severe. But...
Yeah. Laura, how about you?
I would say very severe.
Yeah. Anytime that you have basically a complete conduction block, that's a very severe on a condition. Okay. And that's the type of patient you want to get into surgery as soon as possible. Okay. Because once you release that nerve, if it's just conduction block, then that nerve should pop back and should start to heal. Okay. If it's what do you think the prognosis would have been if in the palm I shocked in the palm and got a flat line also in the palm?
Not as good.
That would still be very severe, but the prognosis would not be nearly as good because a flat line in the palm would indicate a very extreme motor axon loss component.
Yeah.
Okay. So the fact that she did get a CMAP, it's low amplitude, but she got something, means that once she gets released, she has the potential to do quite a bit better. Okay. So how would you like to start your morning with this patient? Okay. These are not the patients I like to start my morning with. I like simple, carpal tunnel cases. Okay.
So on this patient, did you test her left side as well, or just the right?
I did not, because she was asymptomatic on her left side. She had no atrophy. Her strength was normal or near normal on her left side, and she was only scheduled in a 30-minute time slot.
Okay.
So both clinically and from a managerial standpoint, I didn't feel that I needed to go to the other side because with her sensories, I got normal sensories in her ulnar and radial, so I had something to compare to, and then I got a normal ulnar motor also in that same arm. If everything would have been hosed, then I would have had to go to the, to her other side. Then.
Okay. So Mark, if you get a issue on the third, do you ever test through the second to compare or no?
Run that question by me again, Roy.
Well, like I said, if you're doing your third sensory, you ever go and fire and check the second on anyone? Like the second?
If in this case, if her ulnar sensory would have been abnormal, then I'm thinking, oh, could this be maybe a polyneuropathy? Because a lot of time the radial is normal in a polyneuropathy. So if her ulnar sensory would have been abnormal, then I'm certainly going to her other limb. And if I'm seeing the same pattern on that side, then I'm probably checking a sural and a peroneal motor in her leg also. Okay, so this is first case. She leaves, second one comes in. Right behind her. 48-year-old lady. Complaints of right greater than left, arm and hand pain, weakness and paresthesias, also notes neck pain. Symptom, long duration, several years. She finally sought medical attention after the onset of weakness on that right side. Past medical history, back pain, neck pain, cholesterol issues, hypertension, and again, because I'm in an ortho hand clinic, was sent to me by that orthopedist. Tiny lady, 4'10", 113 pounds, but she had atrophy also. Okay. Range of motion normal, except no active thumb abduction or opposition. So at this point, after seeing the atrophy, I'm going, crap. Okay, here we go again. This is my second patient of the day. Strength was normal, essentially, except thumb abduction, opposition, nothing. 0 out of 5. She had diminished sensation in a median distribution, worse in digits 2 and 3. She did have a positive Phelan's test at both her wrist and elbows, a positive Phelan's test and positive Tinel at her wrist and elbow. Okay, so again, I'm thinking, okay, this could be yet another severe or very severe, carpal tunnel case here. Okay, so she was a bilateral study. On her right side, both from, in the long segment, D3 to wrist, and also in her palmar segment, got no response. On the left side, she had prolonged latency, slowed NCVs in both the long segment and short segment, but her amplitudes were normal. Ulnars were good, and her radials, also looked good. So I'm less concerned about this being a polyneuropathy, and I'm thinking, okay, here we go again with another probably, moderate to severe, carpal tunnel. Okay, so again, second patient in a row. Shocked her at the wrist, nothing. Let's just real quick, let's just look at the ulnar first. Her ulnars were all normal. Let me get to this picture here. Okay, so shocked her at the wrist, nothing. Shocked her at the elbow, nothing. Okay, shocked her in the palm, got this low amplitude dispersed motor response here. Okay. And because I didn't see anything happen with her elbow stem, I didn't think that she had a Martin Gruber, so I didn't shock the ulnar nerve there. But again, when I saw this waveform here in the palm, it's low amplitude, and it looks like it's been spread out. So we call that a dispersed response. And what this tells us, when you see it sort of flattened and spread out, it tells us that those fastest firing axons have already been taken out, and the only thing that are left are the slower axons. With her left median, a little bit more straightforward. We had a normal CMAP amplitude both at the wrist and elbow. Had a prolonged latency. Okay. My norm for my lab is like 4.4, so this is a prolonged motor distal latency, but a normal forearm in the NCV here. Okay, so tell me what's going on here with this. I mean, with this right median nerve.
Looks like a severe conduction block again.
Well, how much conduction block, Ben?
Complete.
Complete or near complete on the conduction block here. Okay. And then tell me about this, response here in the palm. Is that a normal response in the palm?
No.
No. What's wrong with it?
Just way too long.
Well, it's low amplitude.
And it's low amplitude too.
Yeah, it's low amplitude and it is a dispersed.
Yeah, I'm gonna say.
Okay.
So could that also be ulnar nerve you're picking up with that one as well?
I was very careful.
Mm-hmm.
It could be, but what this doesn't show is when I got the ulnar nerve, I got an amplitude of about 5 or 6.
Okay.
Okay,
Mhm.
so I carefully moved my stimulator and moved my anode around, and I asked the patient, what fingers are zinging when I shock this nerve? Okay, and they were zinging into mainly her index finger. Okay, and this is a tool that you can use. When I slid that stimulator, medial about a centimeter, she felt the zinging going into her ulnar distribution because I was getting the ulnar nerve. Okay, so don't hesitate to ask that patient, where they feel the zinger. Okay, so I was confident that I was on the median nerve simply because one, I had seen the volume conduction and what the stimulation of the ulnar looked like in the palm, and when I moved back more towards the median part, she no longer got the zinger into her D5, and she was getting it into her D2. So I was confident that that I was on that median nerve. Okay.
Okay.
That's interesting because that's kind of what Dr. Kimura said about watching where the hand's moving
Yes.
and moving
Yeah.
to see what the response was. I hadn't really been doing that because I was so worried and focused on the screen in these last few tests.
Yeah.
Watched it. It makes a big difference.
It makes a huge difference.
Yeah.
Okay.
You're right.
It makes a huge difference. We get so fixated, looking at that computer screen. I don't even look at my computer screen until I see the muscle twitch the way that I want it to. And once I see that, then I look at the computer screen, at that point. So yeah, so that's a really good habit, to get into. Okay. So I needled her again. Tell me what you would expect to see with needle EMG of her right APB with this presentation.
Little to nothing. I mean, no response.
So little to nothing what? Little to nothing spontaneous activity.
Yeah.
Or little to nothing motor unit.
With motor unit.
Yeah.
Volitional.
Yeah, with a complete conduction block, you would expect to see little or no volitional motor unit here. Okay, so let's see what we saw. So when I needled her APB, I saw what I call decreased insertional activity because basically the tip of my needle was pecking her bone because there was basically not much muscle left there.
Yeah.
And then when I tried to get her to activate into abduction, I saw no motor units. When I asked her to oppose, I saw no motor units here. So what branch or what part of the median nerve innervates the APB and the opponents?
The recurrent?
The recurrent motor branch. Okay. And Laura, what other muscle does that particular branch partially innervate?
Is it the flexor pollicus brevis?
Flexor pollicis, what?
Brevis.
Brevis. And the other innervation of the flexor pollicis brevis is from the what?
Ulnar nerve.
More specific.
What do you mean?
Well, there's two branches of the ulnar nerve.
Oh.
The dorsal ulnar cutaneous?
No,
No.
that is a sensory nerve.
It's the deep, isn't it the deep branch of the ulnar
It's
nerve?
the deep motor branch.
Yeah.
A deep motor branch. Correct.
Man, I can't believe I remembered all that stuff.
Yep. So in this case, very similar to this previous case. And again, guys, keep in mind, this is my second case of the day. And it's very unusual to see this type of case maybe once a month or once every couple of months. I saw them back to back here. So what is this lady's prognosis compared to the previous?
Oh, that's great.
Is it better or worse?
Worse.
It's worse because she's not shooting off any motor unit. And when I'm needling her APB, the tip of my needle is pecking off her bone. Okay. Yeah. So what's left of this muscle ain't much. It's probably less than the thickness of a sheet of paper. And there's just not any electrical activity, left in that muscle because it's been so atrophied there. So again, severity of this case.
Very severe.
Again, very severe. Okay. Anytime, you get no activity and combine that with, no response at the wrist. Okay. That indicates, that combination of a significant axon loss lesion along with basically complete motor conduction block here.
What was her what did her did you do FCR?
FCR was normal. It was normal. Okay. Yeah. So Laura, why did you ask me and tell the group why you asked me that question?
Because of the fact that she had no response at the elbow as well.
So okay. Well, she had no response. Yeah, she had no response off the APB at the elbow.
Correct.
If I would have stuck a recording electrode under FCR, do you think I would have gotten a response?
Yes.
Probably. Probably would have gotten a normal response.
Yeah.
Now, Laura, what I think, where I thought you were going with this, is what if I'd have seen fibs and positives in her FCR and assuming she does not have a neck problem and doesn't have a median nerve problem at the elbow. What process could cause a more proximal median
Wallerian degeneration?
Retrograde axonal degeneration. Okay, right. So that nerve will degenerate proximally.
Well, that's why I asked that, because I wanted to know if it started to degenerate proximately, affecting the flexor carpi radialis.
Yeah.
And also I wanted to know because there was no response at the elbow. So
yeah. What I would have liked to maybe do, and I didn't do it because it really doesn't give me any more information. I would have liked to have needled one of her median innervated lumbricals. Okay. So let me ask you this. If I did a median motor test off of that second lumbrical and it was normal, and I did needle EMG of that second lumbrical and it was normal, what does that tell us? This is a tough question here.
I mean, would that not be then the main injury is into the recurrent?
Exactly. Yeah. The primary motor axonopathy is affecting the recurrent branch. Okay, and there could be some sparing of the main motor branch into the palm. Okay, and this is nice stuff, to sort of experiment with, but there's that whole ethical thing about why do I want to do a bunch more testing on a patient, just to show something, when it's not going to add significantly more information to what I already know is going on here. Okay, and I guess if you're super anal, you could say something like, the motor pathology appears to affect primarily the recurrent motor branch with relative motor sparing of the main trunk of the median nerve. But don't I know that the main trunk of the median nerve is also affected?
Mm-hmm.
Yeah.
Yeah. How do I know that?
In response to the elbow?
No. What other NCS response was absent in this
At the
patient?
rest. At the rest.
The sensory response.
Yeah.
Oh, I forgot it.
Okay. And all those digital sensory fibers come off the main trunk. So I know, from my sensory nerve test that both the main trunk and the recurrent motor branch are both affected here. Good. Good thought process. I like this. Okay, so then I did a couple more cases that morning. Then one of the girls, one of the ladies that works in the clinic, comes to me and she goes, "Hey, hate to ask you this, but I'm having some problems with numbness and weakness in my hand." And one of the PAs said that it may be some carpal tunnel, and see if Brooks would take a quick look at you. And this is Danielle. She's super nice. She's a medical assistant there, and and this was at noon, and I'm getting ready to go to lunch, and I'm going, sure, no problem here. Okay, so 31-year-old female, right hand pain, weakness, paresthesias, does note some symptoms on the left, but not to the extent on the right. And this has been going on, she says, for years. Okay. Otherwise, she's a long distance runner, very, very healthy. Okay. Did a quick screen of her, positive to nails at the wrist, positive Phelan's test. She had, this was interesting. Her light touch sensation was intact, except to the median aspect of D4, which is like totally weird there. Yeah, strength I rated as normal. Okay, I didn't get out, any fancy strength tester or anything, because this was sort of a screening type test. So did a couple of screening, median and ulnar sensories. These all look pretty normal.
Yeah.
Yeah. Why is the palmar amplitude so much larger than the digit amplitude when you're using an orthodromic technique? Keep in mind with the orthodromic technique, you guys are used to shocking at the wrist and recording on a digit. Okay, with orthodromic, you're recording at the wrist and you're shocking at the digit. Okay, so I shocked her third digit, then I came in the palm and shocked her in her palm, and both of these were recording at the wrist. Why would the palm stem be so much larger in amplitude than when you shocked out on the digit?
I'd say just close proximity.
Yeah, and close proximity means what?
Well, you're measuring right close to the firing point. So
well, you're stimulating more nerve.
Right.
Yeah, larger diameter.
Yeah, out in
more axons.
Yeah, out in digit 3, I'm just stimulating the two digital branches.
Right.
When I get in the palm, I'm basically stimulating the entire nerve there. So that's why you have a larger amplitude. But anyway, are these findings normal or abnormal?
I would say normal.
They're normal.
Normal.
So normal sensory test. I'm going, what the heck here? Okay. So I did her motor test. Here, here's her motor. And see if let me go back. Her ulnar was normal. So let's go back to the blue screen off of my system. Okay, so I shocked at the wrist.
Yeah.
I got a low amplitude response.
Right.
With a latency of 4.4.
Mm-hmm.
Okay. So are these parameters, I mean, for you guys, I think your norm is 4.5.
Yeah.
Mine is, I told you 4.4, but mine's 4.2. Okay.
Okay.
So a low amplitude response
Yeah.
when I shocked at the wrist and a prolonged motor distal latency. Okay. So we've got a prolonged latency and a low amplitude response.
You got a
Okay.
partial conduction block.
Yeah. So I went and I shocked her in the palm. Okay. And when I shocked her in the palm, I got an amplitude of almost 8 here. And look at the two waveforms. Okay. Look how much tighter this one is together. And look how much more dispersed this one is. Okay.
Yeah.
This is a temporally dispersed response due to the compression. Okay. So describe to me, looking at all this data. By the way, I calculate a nerve conduction velocity through the transcarpal segment for the motor, and the norm is 29 meters per second. Okay, through the carpal tunnel. So somebody tell me what's abnormal here. Tell me what processes or what abnormalities are present.
Well, I mean, obviously we got some axonal issues.
Do we have axonal issues?
No.
Roy, tell me why you think we have axonal issues.
Through the amplitude.
What amplitude?
The 3.6, yeah.
Yeah, but in the palm it's normal.
That's true.
Yeah, so what do we call this?
Partial conduction block.
It's a partial conduction block. It's about a 55% conduction block here. Okay, so again, this is the third patient that morning that had motor conduction block. What else is abnormal here? Based on my norm of 4.2.
You got your latency.
We have a mildly prolonged latency. Okay, and then we've got some fairly significant slowing, through her carpal tunnel, but I normally wouldn't have calculated this because I already have a prolonged latency. So I just did that just to see what it was, and it was 17.9 meters per second. That's giant squid axon slow. Okay, that's pretty slow moving stuff here. So what would we expect to see when we needle this lady's APB? What is the one thing that we might expect to see? What's that one thing that I told you?
The recruitment.
Abnormal recruitment.
Abnormal recruitment.
Yeah. So specifically, Laura, what would we see?
Reduced or fast recruitment.
Well, we may not see fast because it's only a 50% conduction block.
Yeah. But you definitely will see reduced.
We certainly have the potential to see a reduced number of functioning motor units here. Now, at 50% conduction block, EMG might be completely normal. Okay. Remember what Dr. McKibben talks about when he talks about pruning out the tree. Okay. You can prune 75% of a bush off or 75% of the canopy of the tree, and it's still going to function pretty normally. Okay, so the same thing here. You can block or you can lose, up to 75% of your axons, and your motor unit recruitment might still look pretty normal here. So let's see what she actually had here. She had normal.
Mm-hmm.
Okay, she had normal insertional activity. She had no spontaneous activity. She had normal motor unit morphology, and she was able to fill the screen up. Okay, even at a 50 to 55% conduction block, she was able to fill that screen up. Okay, so, it isn't unusual, for about a 50% conduction block to still have a fairly normal, looking, EMG here. Okay, so again, this is an all case here. We had normal sensory, but we had abnormal motor. Okay, so how would you, and this is a tough question, how would you rate the severity of this median neuropathy?
I'd probably say moderate.
Yeah, you'd probably be fine saying mild to moderate, or even moderate, would be okay because of that combination of that prolonged latency and that 55% conduction block there. Okay, what's this patient's prognosis for full normal recovery if she decides to have this released?
Good. Very good.
It's very good. I mean, she'll probably start to feel better, right off the bat. Okay, so getting back into our discussion of anatomy here, why are her sensories normal and her motor abnormal? We just talked about it a few minutes ago here. What innervates the APB?
Recurrent
motor branch. Okay. Yeah.
So
and her sensories being normal, that sort of tells us
this
that the main branch of that median nerve may be spared here. It's probably being compressed because she's having sensory symptoms. Okay, but it's not causing either a demyelinating lesion or certainly not any type of axon loss lesion yet. So we can surmise that the pathology in this particular case is affecting primarily that recurrent motor branch. Okay, so again, just another sort of weirdish case here, and this all happened in a span of about 3.5, 4 hours here on I think it was a Tuesday morning. So I mean, so some weird stuff. Carpal tunnel, or any of these nerve injuries do not fit in a box. Don't expect things to always fit exactly in a box here, because they won't. I had 2 cases of tarsal tunnel today where only the lateral plantar branch was affected, both on the sensory and on the motor test. Okay, so I mean, so weird stuff is going to happen here. Okay, so any questions about any of these cases? Okay, nothing earth-shattering, but what I hope, a couple of things. One, like I just said, don't expect them to fit in a box all the time, because they won't. And then number 2, think deeper about what you're doing. Now, don't become OCD about it, but think a bit deeper. Like in this case here, sparing of the sensory, involvement of the motor tells us that primarily the recurrent motor branch is being affected. And that recurrent motor branch runs in its own fascial tunnel. It has its own little pathway. Okay, so it's entirely possible that the compression, from that, and again, we're going to assume that it was a transverse carpal ligament. I mean, she may have had a ganglion or something in there. I didn't do any ultrasound or anything, but she may have some sort of space occupying lesion in there that is causing this. Okay.
So when you're doing your impression, then you are talking about the recurrent motor branch then in your impression, or no?
In this case, I didn't, simply because this was a screening. Right. I did I did pro bono. If this was a patient, I would note in my impression that the pathology appears to affect primarily the motor component with sparing of the sensory component.
Okay.
I probably at this clinic, I probably wouldn't have gotten into, too much details. Have any of you guys met Sonny Milstead yet? Did you all meet him at the symposium there?
No.
He's the hand surgeon guy that.
Oh yeah, I did. Think back, I did meet him.
Yeah, and he'll tell you interesting stories of him opening up carpal tunnels and just all the variations that you can see what these nerve fibers do. Okay, I mean they go everywhere, and a lot of the cases of patients that have their APB atrophy after a carpal tunnel release, he says is because the surgeon didn't take the time to dissect out and separate the recurrent motor branch from that main branch, and ends up either cutting it or compressing it. Okay. And he said there are lots of variations. He's seen the recurrent motor branch go medial to the main trunk of the median nerve and then cross over it to innervate the thenar muscles. Okay, so these guys have to be super careful when they open up these carpal tunnels, because you're just not sure what that recurrent branch is going to be doing in there and where it's going to be exactly located. Okay, so big reason not to be a hand surgeon, right there.
So be careful who you pick to do your.
Be careful. Yeah. Okay. So that's it for our presentation. Did you guys have any questions about anything other than what we talked about here tonight? Any tough cases, weird cases, questions for me?
I have.
And Ben, I'm probably gonna look at yours here.
Yeah. No,
I mean, hey, you guys, would you care if we pulled up his report here and just took a look at it? I mean, Ben, is that okay, or would you rather me do that?
No, I mean, I'm an open book. I know I messed up, so we're good.
Well, let's. It's not about messing up. This is about learning here. So
yeah.
Let me get out of here, and it's been posted, right?
Yeah, I've got 2 of them posted. Probably the first one's better.
Okay, the first one. Give me the patient initials.
SM.
SM. Okay, guys, I'm gonna close off my screen so you can't see it for a second, because when I open up these files, you're going to see lots of patient names here. So hang on for a second.
Yep.
Okay. Okay, so when I bring my screen back, I'm gonna try to do it so we only see the data here. Okay, so I'm gonna bring the screen back. Okay, can you guys see the screen now?
Yes.
Okay, so I'm gonna try to avoid showing that patient's name. Okay, so history here. Pain, 20 years worth of pain. Nice. 3 weeks ago, tried to pick up a dryer like a hair dryer or like a big clothes dryer.
I think it was like a clothes dryer. Nice. Yeah, it's a clothes dryer. This was another therapist patient.
Okay,
that I
she had
took a look at.
That didn't find anything. Okay, so let's look at the data here. Let's look at the sensory data here. Okay, so everything here, how old is this patient? Not that old. She's about 50. Okay, so looking, I'm going to blow this up so we can see it better here. Here's our sensories. So everything, with the exception of that left sural, everything's just a little abnormal. Here. These latencies are a little bit long. NCV is a little bit slow. No response on that right sural. Temperature's good. Okay, 33 degrees. So I don't think her limb is cold. Let's look at the waveforms. Okay. So those certainly look like decent waveforms. I think this one here, Ben, I think the response is probably right here. And and the shock artifact and the unstable baseline here is I mean, it's probably there, but if it pokes up about right here, it's probably going to be a little bit of an abnormal response also. So all of the sensories are abnormal. Okay, so right off the bat, guys, what's your primary diagnosis?
Some sort of poly.
Possibly a polyneuropathy. Okay.
Yeah.
So let's go look at the motors now. So both peroneals here. Oh, what do we have? What do we have here? Okay. Let's look at the waveforms here. So the left peroneal, if you look at this, amplitude starts out at 5, drops to 4, then drops to 1.8 here, okay, with slowing in that segment. Hey, Ben, who taught you to use 10 centimeters across that fib head?
I think that's just typically what I measured on her when I did that.
Yeah, use 8, please.
Okay.
Okay, because you're going to miss stuff if you're using 10, unless they're 6'6". Okay.
Okay.
So a little bit. She's got some conduction block here. She's got some slowing from knee to fib head. If you look at the right side, everything looks good. This artificially high, this nerve conduction velocity right here. When I see that in a patient that maybe has a poly, I'm thinking this is a technical error. And what do you guys want to bet? That when we look at these waveforms, the waveform with the popliteal stem is going to look different than the rest of them. Okay, so bigger waveform here. So what situation would make this become larger than the previous one?
Little volume conduction.
Volume conduction of the what nerve?
Of the common peroneal behind the knee.
No, volume conduction of the tibial nerve.
Right, where you get the tibial with the peroneal.
I mean, we're testing the peroneal. We're probably overstimulating, getting a larger response, and we're getting some tibial. So that's why we have this sort of artificially fast here. But look at this. Her tibial NCVs are slow.
Yeah.
Okay, so we have slowing in a peroneal. We have slowing in both tibials. 3 out of 4 of her sensories were abnormal here. H reflex. Okay. Ben, is this H reflex? And again, for future reference, don't split your tables. There. Okay. So both of these H reflexes, the system, based upon a leg length of 40, is her leg length 40? Her leg length is 36, Ben. Okay. Okay. So you have to change this shit. Okay. So her leg length's 36, which is going to make this even lower. Okay, it's probably going to be 31 and a half, 32. But either way, both of these latencies are a little prolonged, aren't they? Okay. Does that fit in with the whole thing of a polyneuropathy?
Yes.
Yes. Okay, so we have 3 motors that are abnormal. We have 3 sensories that are abnormal, and we got both H reflexes are abnormal. Let's look at the waveforms. That certainly is a very nice H. Cursor is in the right position. That's a very nice H, and cursor is in the right position there. Somebody's taught you well here. Okay, so based on all these abnormalities in her nerve conduction tests, what continues to be our primary impression at this point?
Polyneuropathy.
Sensory motor polyneuropathy. Let's look at her EMG here. Okay, so pronatus longus, tibialis posterior, reduced recruitment, and I'm going to assume you mean and increased motor unit amplitudes.
Yeah.
Here. Okay. Same on the other side. So these are L5S1 muscles. Answer me a question. Why the heck did you check the middle lumbar paraspinals? Why did you check L2 through L4 instead of L4 through S1? Or both?
Probably labeled that wrong because I was probably in the lower ones actually.
Okay, so let's go ahead and relabel that. On that left side, we see some increased numbers of polyphasics. You cannot do recruitment with paraspinals. Okay. Just can't do it. So we're going to call that normal. But we've got increased number. Now, does this change anything from our primary impression?
I thought I was after the EMG, my mind started going into more of an axonal issue within the L5.
Well, it is an axonal issue, but is it nerve root or is it a sequela of her polyneuropathy? Or can we tell?
I don't know if we can tell.
We can't tell. Okay, so let's go up here and let's look at your impression. Okay, and again, missed a couple things here. Okay, bilateral peroneal motor NCV. It wasn't bilateral; it was just on the left side there. Okay, and there was also conduction block here. Correct. So let's go ahead and put in a blurb about the conduction block. Both these tibial motors were slow, right? Okay, so we need to put a blurb in here about slowed tibial motors. Both of her tibial H latencies were prolonged. So in our nerve conduction summary, we need to put in a blurb about the prolonged H latencies. Right sural was not recordable in bilateral peroneal sensory. NCVs were slowed. What else was abnormal in addition to the NCV? In a sensory nerve, if the NCV is slow, what other parameter has to be abnormal?
The onset latency.
Oh, yeah, I was going to say onset. The latency.
Yeah.
Okay, so bilateral peroneal sensory nerves exhibited prolonged latencies and slowed NCVs. You add all that together, that sounds awful polyneuropathy-ish to me. So let's see. Benjamin.
Yeah.
Benjamin. Okay. So what's her main issue?
The polyneuropathy.
Yeah. So how do we write this? Okay.
Very good.
Extreme extremities. Do we agree?
Yes.
Yeah.
Okay. And then for number 2, what are we going to say?
The superimposed.
Do we agree?
Yeah.
Yeah.
Okay.
Because look,
Mm-hmm.
she's got conduction block in her left peroneal nerve that could be focal and or that could be as a result of her polyneuropathy. She's got slowing in this segment, which could be focal and or could be due to the polyneuropathy. Okay, so but we can't say for sure. In the context of a polyneuropathy, we can't say for sure. Okay, and these distal muscles that were abnormal here, okay, extensor digitorum was abnormal here. You know, what did Dr. Kimura say about polyneuropathy and intrinsic foot muscles? In the University of Iowa, in their neurology clinics, what are the 3 things that they look at to determine if a patient has a polyneuropathy or not? First one, abnormal sural. Does this patient have an abnormal sural?
Yeah.
Yeah. What's the second thing he said? Abnormal tibial F wave. You didn't do an F wave, but you did a tibial H.
Mm-hmm.
Is this normal or abnormal?
Abnormal.
You're 2 for 2. What was the third thing he said? Abnormal EMG of intrinsic foot muscle.
And then, yep, the extensor
And so you're 3 for 3 here, right?
Mm-hmm.
That old guy's got some wisdom, doesn't he?
Yes,
Yeah.
he does.
Yeah. Okay. So Ben, I've rewritten your impression for you.
Okay.
Does everybody agree that this would be correct? And does anybody, Laura, would you suggest any refinements to this impression?
To the impression?
Yeah.
No.
The way that I worded it, how would you word it different?
I'm just reading it. This enzymatic axon. I don't think I would. I mean,
Thank you.
yeah, I don't think I would add anything.
Woo!
I'm reading it. I'm like, I don't see anything. Is this a trick question? I'm like,
No, it's not. I mean, you're board certified, so I'm asking a colleague here, if they would state anything different. What one other thing would I have done? What
would you
what
say
two other nerve tests? What 2 other nerve tests would I have done with this patient?
Would you have done an upper extremity?
I would have done an ulnar sensory and a median motor study.
Yeah.
Yeah. And that way, if those came back abnormal, then I could say evident in all extremities tested.
Mm-hmm.
Okay. And
So
that would
ulnar sensory median motor.
Ulnar sensory and median motor, and I'm looking for that forearm velocity.
Okay.
Okay. I wouldn't do a whole EMG on that upper. Wouldn't do it. Wouldn't add any more information unless you suspect that she has, some carpal tunnel syndrome or something like that. Okay. There was no electrophysiologic evidence of proximal nerve plexus or nerve root pathology, myopathy, or motor neuron. It's funny here, Ben. Your original impression talked about nerve root pathology, but you left it in here. But it turned out to be a poly, but you took it out in this section. So I think one part of your brain was wanting to do one thing, and the other part was, was thinking on a different plane there. Okay. So good data here. Okay. Good data. Just need you to tidy up this nerve conduction summary with all of the abnormalities here.
Okay.
When you have good data to start with, nice waveform, getting a little tibial here also, because you can see how that's changing shape. But overall, good data. And if you have good data, you arrive at a correct impression here. Okay. So I'm gonna go ahead and exit out of that, and I'll save it there. Just go ahead and tidy those up there, and I think this one will be all set to go.
Okay.
All right. I have to get going, Dr. Brooks. So I'm gonna sign off.
We're it's crap. It's almost 9 o'clock. We're gonna shut down here.
Okay.
Guys, if you have any questions about anything, shoot me an email or text me. And I hope this has been informative for you guys, and look forward to seeing everybody on the next webinar. I do.
Yeah, Mark, it's always good.
Roy, good to talk to you.
Hey, same here. We can try and keep it up.
I will. See you guys.
Right.
Bye-bye.
Bye.
Bye-bye.